We are recording. Welcome, everyone. Good morning. I am April Harrington, the project manager of the Chicagoland Healthcare Workforce Collaborative. If you haven't already, please introduce yourself in the chat so we know who's joining us. For anyone who is unfamiliar with the Chicagoland Healthcare Workforce Collaborative, we are a group of employers and industry partners who have come together to support an inclusive healthcare workforce and provide accessibility to underemployed and unemployed populations, while also meeting the ever evolving and growing needs for talent in the healthcare sector. We are primarily a peer learning space, but we also do a little bit of research and direct programming as well. Here's a little snippet of some of the partners that are involved. We are employer-led. 6 of our large hospital systems make up our steering committee, but we're also supported by our strategic partners, including community colleges and other training providers, workforce development, organizations, funders, advocates, and anyone engaged in building a stronger, more inclusive healthcare workforce. Next week, next Tuesday from 8:30 to 10 a.m. is our first quarterly meeting of the year. So I hope most of you will attend. It is virtual. I will drop the link in the chat, and I've included the agenda here. We will go over some of the results of our end of year survey from last year and present our goals for the 2025 year. We'll also have a little overview of the local healthcare workforce from Lightcast reports, have a little bit of discussion about that workforce data. I've invited someone from the Illinois Health and Hospital Association to give a little policy update, talk to you about what IHA does in the policy space, what they are focused on at the federal and state level right now as things are a little crazy, and some workforce initiatives that they'll be focused on at the state level down the pike. And then finally, we're going to give an update on a grant initiative that CHWC is working on in partnership with Malcolm X City College of Chicago and the Chicagoland Workforce Funder Alliance, with the goal of increasing Black male participation and success in healthcare pathways. So I will drop the link to register for that in the chat right now. We also have a Public Health Workforce Collaborative March quarterly meeting. If you are not engaged with the Public Health Workforce Collaborative and you'd like to be, just shoot me a message. Andrea here today is also from Health and Medicine Policy Research Group and can probably get you registered for that. With that, and just want to state we're recording today's event. We will also record that quarterly meeting. Recordings and slides are uploaded to our website, usually within a day or two of the event. So you can look at our past events and you can find the recording of today's event and today's slides, likely starting tomorrow. And without further ado, I'm very excited to have a team of researchers from the University of Illinois Chicago Center for Healthy Work joining us today. They have been engaged in a research project with a mid-Atlantic health system, studying the organization's effects to implement an equitable culture of health and well-being. And so I won't get any further into it, and I'll let them speak. We have Preeti Pratap, Emily Steele, and Bruce Sherman joining us today. I will stop sharing my screen and hand it over to Emily Steele to get us started. Please feel free as they're presenting to drop any questions in the chat. I'll be monitoring that. And we will certainly have time for discussion and question and answer, especially that it's a small group today. I hope you all feel free to engage in some questions. So with that, I'll hand it over to you, Emily.
Thank you. And I'll hand it to Preeti to kick us off, but it's nice to see everyone.
Yeah, and we'll do some quick introductions when we come to the next slide. Good morning, everyone. Thank you for being here today. The Workforce Health and Wellbeing for All as a Sustainable Business Strategy is a research project that is part of the University of Illinois Chicago School of Public Health Center for Healthy Work. The Center for Healthy Work is one of the 10 total worker health centers for excellence that is funded by NIOSH, which is the National Institute for Occupational Safety and Health, that is part of CDC. And so we are one of the centers, and our center was established in 2016. And this project is part of that center, and our project began in 2021, September. And the mission of the Center for Healthy Work is to turn unhealthy work into healthy work, and specifically focus on precarious workers and low-wage workers, and focus on their promoting and supporting their health, safety, and well-being. Next slide, please. So our research team, I'm going to quickly introduce myself and then pass it out off to my team members. I'm Preeti Pratap. I'm faculty in the School of Public Health and Environmental Occupational Health Sciences. I'm a research assistant professor, and a lot of my work is around, operationalizing health equity, not just in communities, but also in organizations. And so I'm going to pass it over to Emily, who is my co-PI on this project.
Hi, my name is Emily Steele. I'm a clinical associate professor in health policy and administration in the School of Public Health. And my background is more on the organizational behavior side. So understanding employees in organizations and what motivates them and sort of what retains them and what causes turnover and things like that. So it's nice to meet everybody. I'll turn it over to my colleague, Bruce Sherman.
Hi, everybody. Bruce Sherman. It's a pleasure to be here. I am a physician by training and researcher for the last several years, have a background in corporate medicine as a corporate medical director at 3 different Fortune 200 companies. But my primary interest for the last 10 or so years has been related to health equity, particularly in commercially insured populations. And it was a pleasant surprise to connect up with Emily and Preeti to collaborate on this project. At the time that we started, I was in a role with the health system as a providing medical support to the benefits team related to the employee health benefits. So it just was a wonderful fit, and it's been a pleasure working with Emily and Preeti for the last few years. Back to the two of you.
Thank you, Bruce. We have, just like any other research grant in our institution, we support students and, provide stipends and research opportunities. So we've had a couple of research associates go through our program. Currently, Noor is our graduate research assistant on our project. And Rukshana and Caroline worked with us previously and have moved on into jobs. Next slide, please. So I think for any research project, anything that we do, it's important to really understand why we're doing it and what we're really passionate about. And for us, I think, the main foundational piece was that employers have a role to play in population health and well-being, because we all spend a lot of time at work. And this is like such a significant part of our life. Everybody works. And so what happens in the workplace and what kind of work you do and the conditions of your workplace really can actually impact every other aspect of your life, of your health, and your well-being. So several organizations have been trying to do a little more about culture of health and talking about health equity, but really talking and walking the talk are two different things. And, we've heard this in different circles, but the challenges that they experience in really operationalizing cultures of health and health equity. And a lot of organizations really focus on health promotion efforts, right? Really thinking about physical health, mental health, financial health, and having a really holistic approach to health and well-being. But the focus is always on providing, equal opportunities for all your employees. All our programs are available for all our employees. But in reality, there may be several employees, especially employees in the low-wage categories, job categories, or who are predominantly minority employees that may not be able to fully benefit from these health and well-being offerings Thereby, it's possible that these health and well-being offerings may be exacerbating inequities, health inequities in your workforce. So that is the thinking that we started this project with, and really working with this business partner, a Mid-Atlantic health system that has already done a lot of work in this space and was a pioneer, but wanted to do more in operationalizing an equitable culture of health and well-being, and really looking at data and, providing data and that connection to business outcomes within the organization, which is important to make any of these efforts sustainable. Next slide, please. So the specific aims, were research studies. So our aim was to use data from within the organization to explore the unmet social needs amongst the different employee, worker populations, especially the low wage workers, and really trying to see if they, and look at if they are impacting business outcomes, like trying to look at the data from within the organization. In this, the second aim focused on developing a roadmap with the organization, an equitable health and well-being roadmap with the organization. So even when our project is done, they have a roadmap that they can follow and continue doing this work. And then the third aim was to at least develop one pilot intervention that not just focuses on interventions at the individual worker level, but really focuses on changing the policy and system to really support equitable health and well-being within the organization. Next slide, please. So our project started in 2021. We are supposed to wrap up in August 2026. 3 phases of the project is what we plan. Phase 1 was data collection, like collecting qualitative and quantitative data, which we will share with you today. Phase 2 is how we've been engaging with leadership from the C-suite to mid-level managers to supervisors in really understanding the assets within the organization and how we can think about some interventions. And we're in phase 3 right now, where we're finalizing our intervention and implementing and evaluating it. Next slide, please. So this 3-circle model is what we are using in our approach to our work. Whatever we do, whatever decisions we make, we're making sure that it's embedded in the evidence. So looking at data from within the organization or gathering new data and bringing a health equity lens to that data. So then organizations don't have to always think about having someone from outside come and do it, but that you have data within the organization that you can look at to identify inequities. And then use a systems thinking approach. All organizations are trying their best. Many organizations are trying their best to do the right thing for their employees. So find out what are the assets and existing initiatives, who are the leaders, what are they doing, and trying to see how we can build on those existing initiatives, than walk in as researchers and say, oh, this is what you need to be doing. And then the final piece, which is the most important piece, is having a human-centered design approach to the work we're doing, because you can't build things for people without their input. So how can we engage the employees who are impacted by these inequities, and how do we engage them in designing benefits and systems in the health and well-being space that is, most useful to them and helps them thrive and grow in the organization. Next slide, please. So with this, I'm actually going to hand it over to Dr. Sherman to talk more about our whole evidence and data piece of our study.
Thanks, Preeti. If we can go to the next slide, please. What I would like to do, actually, let's go, I'm sorry, if we can go back one, my apologies. Yeah, what I wanted to do is just talk a little bit about our approach to the data analytics, and thinking about this in the context of demographic data. We wanted to make sure that we had a good understanding of the population level detail of employees within the organization. Again, primarily focused on the employees, not dependents. We wanted to characterize both the race and ethnicity data, but also wage band. And some of the previous work, research in which I've been involved, we've used wage band quartiles to identify differences in subpopulation level behaviors based on income. And one of the things that we did, as in prior studies, is split the lowest wage band into, so that lowest quartile into 2 separate groups. So each of them, the quartiles has roughly the same number of individuals. We then use that as a basis for evaluating claims data as well as clinical data being a health system, the organization had access to a moderate amount of clinical data, particularly in relation to chronic conditions. And then we were also able to get access to some well-being program data, which I will confess was not the easiest thing in the world to do, but it was certainly helpful in terms of understanding the overall significance of those data in relation to the demographics. So I want to take you through just a few slides of data. If we can go to the first one, the next slide. Here you just get a sense of the demographics by race, ethnicity, and wage band, and you can appreciate a majority of the employees are white, with a sizable proportion, a sizable minority of employees who are Black, with smaller numbers of other individuals. When we look at the wage categories, you note that there is a decidedly upward shift where we would think that we would see proportions of individuals divided relatively evenly. We see the lowest wage, which is $32,000. Interestingly, which is a mandate from the organization. They're slowly raising the minimum wage. Right now it's $16 an hour. If we go to the next slide, you'll appreciate that when we look at the combination of the two variables, what we see is in the top two sets of data, left and right, for white and Asian subpopulations, you notice that the distribution of individuals is shifted decidedly toward the top two quartiles. But when you look at the bottom two, the Black and Hispanic subpopulations, what you notice is that there is a preponderance of individuals in the lower half of the wage category. So clearly some inequities or disparities in distribution of individual employees on the basis of wage and race and ethnicity. Next slide. When we look at condition prevalence, we also notice differences in or disparities in condition prevalence, and particularly among individuals who are Black. We notice that the prevalence of obesity, hypertension, and diabetes is significantly higher in each of those populations. And that wasn't a particular surprise to us, having been involved with the employee population. The other two variables on the right side, the Charlson Comorbidity Index, which is a measure of disease burden, and the PDG, which is the psychiatric diagnosis groupings. You see that the Charlson Index shows a higher aggregate burden of disease among the Black subpopulation. The PDG shows higher disease burden among the white and multi-racial, multi-ethnic populations. So these numbers give us a sense of where to go or how to start to think about targeting the different subpopulations. And what you notice is that when we start looking at clinical measures, we see that hypertension control overall is worse in the Black subpopulation and relative to the Asian, Hispanic, or white subpopulations. And this is this was, I think, for the organization, one of the first areas of disparity that they had appreciated. Previously, the data were looked at on the basis of aggregate detail, not on a race, ethnicity, or income breakdown. So again, here's a starting point for a significant health condition that appears to be suboptimally suboptimally managed in the Black population. Next slide. When we look at, here's an example of how um, income affects or influences um, uh, participation in the organization's health incentive program, which is a function of, or the incentive is a reduction in monthly premium costs that one can appreciate here. High wage workers are much more likely to complete, but as wage falls, one notes that the participation rates fall in all of the different racial and ethnic subcategories. So this starts to really help us understand that even in commercially insured populations, a one-size-fits-all approach or combining aggregating data without regard to population subsets may not be a reliable way to look at the data when it comes to the behaviors in specific subpopulations. Next slide, please. Thank you. So when we look at emergency department visits, we see a similar kind of pattern where income or wage category is associated with utilization patterns. And we'll talk a little bit more about this, but the key point to make here is that while we see these differences in population subgroups, what we don't appreciate is the fact that these data point out the existence of an issue, but they don't point out what the root cause is. So what we don't know is whether this is an issue of shift workers being unable to access healthcare, whether it's an issue of affordability and benefit design, whether it's an issue of healthcare access, that outside of work, low-wage workers don't have ready access to healthcare providers, or whether it's a matter of employee trust in the healthcare system. So this is a great place to start, but it doesn't give us an answer as to what's going on. And important to keep in mind. Next slide. Similarly, we see preventive care visits being higher among the high wage workers relative to the lower wage workers. Again, this is raw data for people who were fully enrolled in the benefits plan. And again, it raises concerns about what the issue is with respect to why individuals in low wage categories, and particularly those in minority categories, are minority subpopulations aren't accessing preventive care like individuals in higher wage workers in higher wage categories are. Next slide. Here's a bit of different data, and we'll talk about how these data sources and the potential for them to be aggregated. But you'll note that in this slide, we see that turnover rates at 90 days, 1 year, and 3 years for these different populations of workers in traditionally low wage categories are significantly increased. And when you just compare the sort of the gold colored graph to the blue for 2024, you can see that of the 333 workers that were hired at the beginning of the year, 229 of them had left by year's end. And that's a pretty impressive turnover rate. And most of those, as you can appreciate, 164 were voluntary. So big opportunities. And what we don't think about often enough is what's the business value of, what are the business implications of these kinds of data. So that really helped us focus more and more on this, on these low wage workers. Next slide. Emily and Preeti, if we have time to stop now, if you want to continue, we can. but just wanted to query the audience about their experiences with looking at quantitative data as we have in this fashion, and whether findings are similar or different, whether there's anything that is unique or has resulted in triggering some action on your organization's part to look at these data and do something about it.
And feel free if you'd like to drop in the chat, or if you want to raise your hand and let us know. We'd love to hear from you about what your organizations are doing, or, are there things that you would like to do with data like this?
This is the audience response portion of our presentation.
Or does anyone have questions about the data that was shared so far?
Good morning again. This is Annette. I think it's a lot of data that was shared, and with all the data that's being shared, the question that was coming to mind for me was, how do we make a difference with this data? How do we get this info out there to share with them? I could think of reasons why maybe the lower income people don't use preventive measures for healthcare, because they don't know that they can. They don't know that these options exist. And if they do know, they're afraid about missing work, and it's going to affect their benefits, or trying to get a raise, or I don't have time for this because I got to deal with childcare and I got to deal with other stuff. When it comes to trying to think about the population in like the areas, because as you all were saying, it was kind of like all over the place. It wasn't like concentrated in one particular area. That could be another thing that may have something to do with it. It could be a variety of different reasons that it's affecting people. It's interesting, but it also makes me think even more. What do we do with this data? How do we help these people? How do we make a difference? And I don't mean to babble, but I'm just thinking about everything that was being said. I would love to look at the slides, April. So
Yeah.
just to think about it, like, how do you really make a difference? How do you keep encouraging someone to move forward when they don't feel like they're making any progress? And with that being said, I'm going to pass the torch back to you all and stop babbling.
Yeah,
Thank you all
wonderful.
for the opportunity.
Absolutely wonderful, Annette. I'm so glad you shared what you shared, and it's a wonderful segue into the next part of the presentation. But I think you have highlighted so wonderfully well the fact that looking at the data is only a first step in the process, and we really have to understand what's going on for individuals that cause them to manifest these particular behaviors when it comes to using healthcare. And that is an absolutely critical part of coming up with a solution. We are naive if we think we know best. And sadly, there's a lot of that going around where benefits personnel who are, I would say, preponderantly white and higher paid are making decisions based on what individuals who are predominantly in minority races and ethnicities need in those lower wage categories. So thank you, and perfect segue to the next part of the presentation.
And if anyone has anything else, please feel free to drop it in the chat too. Yeah, and as April mentioned, we do have some papers that we can share. We're definitely sharing these slides after today. But maybe, one of the things that we can discuss is just, we also agree. One of the things that we heard is that we had done these interviews and focus groups, which I'll talk about in a second. And a lot of the leaders in the organization said, oh yeah, we've heard that a lot. We've heard that a lot. As soon as we paired that quantitative data to show sort of the evidence for why these disparities existed and how they existed, all of a sudden people started paying attention. And then we could blend the two and actually start talking about what do we do. So one of the things that we have here, we conducted interviews with leaders in the organization, 19 mid-level managers, directors, and C-suite leaders. We also did focus groups with 61 employees from sort of frontline or low-wage occupational groups. So these included environmental services, nutrition, lab techs, certified nursing assistants, security, office staff, and then one group of supervisors. We had multiple shifts across 3 different hospitals, so that we could get, as many pieces of input as we possibly could. One of the things that we heard right away is that the organization has been trying. And so across leaders and employees, we heard that there are a diverse set of programs that really look at health holistically. There is a commitment of leaders to employee health and well-being, and that managers and peers would sometimes really help to let people know about what programs were available, or to bring in representatives from human resources or people in culture to talk about some of the programs that employees could access. At the same time, there were these differences between what leaders perceived and what employees perceived. So there was a holistic view. Again, leaders championed this holistic view of culture of health. But when they would talk about health equity, they were often focused on the patient population. They said, we're doing a lot of great things in our community. When asked about whether that health equity applied to their employees, they would often say, well, that's a good point. We haven't really thought about it that way. There was also an awareness from the leaders that there were issues that employees were facing that they didn't always know how to help the employees to deal with. And there was really just a general lack of data, that people didn't even know, what are the issues that we should be paying attention to. They didn't feel they had the data to do that. There was also this perception from employees that they were disconnected from the broader organization. There were signs all over the organization saying, here's our culture, we value employee health. And employees sometimes felt like that didn't actually apply to them. That was for the community, that was for other stakeholders, that was just the thing that checked a box, it doesn't mean me. There were also some policy issues and barriers that we heard, like clocking in and clocking out. A fear that if I left to go take care of my health during the day, I would get penalized. And if I got enough penalties, I'd be fired from my job. And then some employees talked about a lack of opportunity, that, they'd been there for 20 years. Maybe they applied for different positions within the organization, but they never had that opportunity to move up. And so just thinking about, what does that mean for employees? So, just thinking about the quantitative and qualitative together, again, what we're finding is that there's an intersectionality between wage and race ethnicity. And there are these disparities that we're seeing in terms of health outcomes and control of disease, sort of control and management of different diseases. We're also seeing from the qualitative lens that the organization is trying to invest in a lot of different programs, but there's not even really data on who's participating in those programs, or whether those programs are having the intended benefit on employees' health and well-being. We also heard a little bit of a lack of trust sometimes in the general broader organization. Employees sometimes heard, oh, we care about your health, but when they would try to take days off, they would be told, well, we're short-staffed, so you can't take the weekends off. So there's kind of this misconception sometimes. And there were also differences because the organization left a lot of the health and well-being sort of implementation to frontline supervisors, who were also overburdened. And we're trying to manage these tensions between taking care of patients, having short staff, getting staffing ready and available, and taking care of their employees. So, one of the things that we decided to do was to start looking at, why is health equity so important in organizations? For those of you who have heard of Maslow's pyramid, you'll see on the left-hand side here that, Maslow describes these different unmet needs that people can have. Unmet needs for physiological needs, food, water, sleep, oxygen. If you don't have those, it's really hard to focus on higher order needs, like the need for safety and shelter, or the need for trust and belonging and social connectedness. In the same way in the workforce, employees have these basic needs that have to be met. Some of those needs occur outside of the organization. So I think you mentioned childcare and, even needs for, am I going to have enough to have food this month? Can I pay my rent? Will I have shelter? Can I take care of my children? Things like that. Those are needs that occur maybe outside of the organization, but they definitely blend into the organization, and they impact, employees' ability to really be focused and to meet some of those higher order needs to become a high-performing employee. Just a quick stop again. One of the things that we're wondering is, has your organization talked about health equity? And I know with some of the organizations that are here, you are having very complex conversations about this, but we'd love to hear a little bit about, some of those conversations before we dive in to our project and what the next steps are. And again, feel free to raise your hand, chime in, or you can even drop in the chat sort of what health equity means in your organization. And if you've been taking measures to think about health equity for employees and employee health and well-being.
This is Phoenix from Rush. I think Rush actually does a pretty good job when it comes to health equity. It is one of the pillars that we work on both in the community, but they do a pretty good job of bringing it home to the people who work there. And I think one of our biggest failings or opportunities for opportunity is communicating those well. So some individuals may not have as many technological skills, and a lot of our offerings, our opportunities, the information to get there, it's all funneled through our online internal system. So if you're not comfortable navigating, or you don't know technology, or that's not where you go to get information, it really then falls down to the leader and the communication and relationship between those employees who are not as tech savvy and their leader to say, oh, hey, I know that you're struggling with X. Did you know that we have something? Because we, to our credit, like we have something for most situations, not everything, but a lot of them. But connecting our staff to those opportunities is where we have some opportunities, and we're starting to work on that and chip away at it, but we have not mastered that for sure.
And I will say you are not alone. I mean, I think we saw a similar thing in this organization, that they have so many programs that if someone needs something, there's probably a program to meet that. But connecting the employee to that program, and also, helping them to actually use that program. I think it's also something to say, oh, we have a website, just go to the website and find information. But for the employee to navigate the website, to figure out how to make the phone call, what paperwork they need, how to actually get the resource that's there, is also really challenging. And I appreciate the emphasis on psychological safety too. One of the other things we heard is that for frontline employees, there were sometimes these issues of trust, as Bruce mentioned, that even if they felt like, oh, I have this benefit, okay, well, but if I go and see a primary care physician and they tell me that I need additional care, do I have the time and effort to actually follow through on that? Maybe it's easier for me just not to go. Or, what if I go and, that first visit is free, but then I'm going to end up paying a copay, or I'm going to have variable pay for the future. I don't know if I can afford it. Definitely. Anything else? And I also appreciate the hierarchy of need there. So, thinking about this, one of the things that Preeti mentioned is that we're really trying to take a systems level approach in our solution here. And this is by far, not the only solution, but we're trying to take these steps to think of a process for addressing health equity in the organization. One thing was, we took these findings and we decided to try to understand what the system was already doing around these issues, and then how, different system leaders were thinking about the findings that we had. So we had interviews, again, meetings with leaders after we had done the focus groups, the interviews after we had the quantitative data, to share program-specific findings, but then also to ask, how could we support your work? What could we do to help you to address health equity in the role that you have? The other thing that we tried to do is to really bridge across and between different divisions or work groups, because the organization had a lot going on. They had a center for health equity. They had a center for people and culture. Their human resources department was trying to do some things. They had health and benefits, but the groups weren't necessarily always talking across each other. And communication was a big issue in this organization too. You mentioned the online system. There were some employees who didn't have access to a computer during the day. They were out on the floor. And so if health and well-being initiatives are being emailed or being sent through the online system, they weren't receiving any notifications about those at all. Just to kind of highlight, it's correlation is not causation, so we're not trying to claim that, but in the during the time that we've been talking with the organization has made several changes that sort of align with some of the initiatives that we've been promoting around health equity. You can see some of these here, but one thing is in talent and acquisition, they're really trying to build this job architecture. And I know that a lot of organizations in Chicago have been doing that too, like the Health and Medicine Research Group, but really trying to say, as you come into the organization, where could you go if you wanted to go? What are the potential jobs that you could think about moving into? And what are the requirements that you would need or the skills that you'd need to develop in order to move there? They developed a group of wellness warriors who are representatives from each of the different divisions or each of the different work groups. They had representatives from some of the lower wage occupational groups to really talk about, what are the needs around health and well-being? What are the resources that we have? How do we better communicate those resources to our employees? And sometimes the wellness warriors would act as sort of peer mentors to tell their colleagues about some of the programs that were available. There's also been a big push around data analytics and infrastructure to make sure that there's timely and accurate data that's available to the team. The organization recently hired a chief equity and belonging officer to really focus on the idea of trust and belonging to supplement some of the work they're doing around health equity. I just wanted to show, some of the thinking that we've been helping the organization to do around a health equity roadmap. It really has sort of three pillars. The first is data and evidence for action. So we're trying to figure out, how do you take this data and highlight some of the needs that employees might have or some of the disparities that might exist in your organization. The second thing we're trying to do is really build health equity into the ecosystem of the organization. So figure out, how do you operationalize health equity so that if there is a problem, you know what the process is for trying to prioritize that issue, for finding solutions to that issue, and for implementing some kind of action plan to address or solve it. And then finally, the third pillar is an equitable culture of health, where we're really trying to have employee ownership, where we're figuring out, how do you get employees to feel like they belong in the organization? How do you build trust with your employees? And then how do you help to involve them in the decision-making, in the selection of criteria and of different health and well-being initiatives? And so with our pilot, we are working with the organization now to develop a pilot intervention that mirrors some of the things that we've seen in Chicago around sort of a coaching intervention that connects both health and well-being resources and employee career advancement and development resources to employees as soon as they start in the organization, so during orientation. What we're hoping is that by having sort of that coach, it's first of all going to connect employees to those resources that they need and actually help them right at the beginning to start off on the right foot, that they feel supported, they have resources, they have access to the resources that the organization may already be providing, but letting them know what that is. We're also hoping that having a person there to kind of help them through it might help them to actually make the phone call or to follow through on the phone call, or to make sure that they've scheduled appointments for primary care or gotten in touch with resources around housing or rental assistance. The other thing that we're hoping is that by engaging in this coaching program, I think, as Bruce demonstrated, turnover is really happening quite quickly. There's a large proportion of individuals who are leaving as soon as they start in the organization. We're hoping that with this coaching intervention, we'll be able to, catch people early on, figure out what they need, how to let them feel like they're part of the organization so that maybe we can retain them and retain really high quality employees who otherwise might leave or feel, disconnected from the organization. And then I want to turn it over to Bruce just to talk about some of the lessons that we've learned and some of the thoughts around, how health equity might be different from some of the DEI initiatives we've talked about earlier.
Thanks, Emily. Yeah, just to run through these lessons learned, I think our eyes were opened to the fact that many organizations think about this kind of work, but for health equity, it's not really the province of DEI. It's not necessarily the province of benefits. So trying to find a home within the organization to incorporate this work at the beginning was a bit of a challenge. And part of the way we did that was to focus more on the business value. And there's some excellent work from Gallup, the sort of the connecting the dots to business value is employee engagement, addressing some of those unmet needs, building trust, and that employee engagement translates to enhancements in business performance measures, greater employee retention. And one of the things that we're trying to do is with the data is now connect what we have to measures of business performance. One of the big issues that we've appreciated is that many within the organization have had either other priorities or feel like they are already doing what we are discussing. And to that end, we have run into barriers with advancing our agenda. Fortunately, I think we've gotten now the attention of the senior leadership team, the entire people and culture group, which includes employee engagement, retention, career advancement. So we're appreciating that that we're making progress. This next to the last bullet should be employee empowerment fosters alignment, because it's clear that, as was demonstrated, I think first in the 2007, I think a Towers Perrin study showed that my employer cares about my well-being is one of the best triggers for or drivers of employee engagement. And that seems to be one of the key focus areas for us is how do we foster that greater engagement? And then patience. This has taken us, I think, longer than we had expected to get to where we are today, but we are moving forward. And despite frustrations, it's been quite satisfying to see the progress. Next slide. I just want to talk a couple of minutes about health equity and DEI. I know that there are tremendous sensitivities regarding DEI at the moment, given the current administration. And I know that I think it's Denver Jewish Hospital has succumbed to threats from the government and has removed their DEI policies. I would submit that health equity is different. And while they both address inequities and they both involve ensuring fair and just access to resources, whether it's optimal health or optimal opportunities for career, wages, and advancement, there are differences. And the big difference is that health equity is very much an individually centric function, whereas DEI, at least in response to the current administration, is not posing or doesn't pose a threat to other people. We're seeing this pushback on DEI, and certainly be curious to hear how others have experienced this or are talking about this. But I think that health equity is a much more foundational attribute and objective for employers with measurable business value, and that should be something that we continue to think seriously about. Next slide.
So I think that's kind of what we have today, but we would love to open it up. I know we only have about 6 minutes left, but just discussion. One thing that we're really hoping to do is to, again, continue this work with this hospital system in a mid-Atlantic state. We're also really interested in thinking about potential collaborations to either develop something like this in an organization, if your organization hasn't already, or to work with different healthcare organizations to think about how can we sort of map out this process and map out some of the work that you're already doing or evaluate some of the work that you're already doing around health equity. So we'd love to stop now and, take any questions that you might have, hear your thoughts about what your organizations are doing around health equity, and just think about, what is the future and what are some of the challenges that organizations are dealing with around this issue.
In the chat, Brandon had mentioned the wages for certain, and I think he specified the PCTs and CNAs, but there's a lot of roles in our organizations that are not living wages. And obviously that's not very equitable, but I also understand the flip side, it's just a matter of business, right? Can we sustain those wages for all roles? And I'd like to figure out a way to do that, because I think that's fundamentally, it's core to anyone's health, is being able to have a living wage, because it allows you to open up your mind and relax and have time to think and be critical in what you do and plan and all those things. And when you're just running through, I need money and working a lot of hours, like you can't be as effective. And I think that's probably one of the biggest difficulties and one of the things that could have some of the biggest impact. So trying to figure out how do we offer sustainable wages to all roles? How can we do that?
Yeah, thank you, April, for bringing it to attention. And the example I gave is like the military, right? So the military salary for an engineer or even a physician, it's not the same as a civilian, but they get all those other military benefits that makes it very competitive, if not even more competitive, post-military. A clear-cut example, when I was at Columbia College in Chicago, it's a small arts college, they're having some tough times now, but one of the benefits I thought was so interesting is that we had a physician on staff at Columbia that you could go see, like your primary care right there on campus. I don't even think it was a copay. It was part of the union negotiating. I don't know if they still have it. This was a few years ago, but I thought that was so wonderful. I mean, I had the primary care, but I would utilize that doctor just because I'm on campus and he's there for free and he was good. He was a good physician too. Something like that. So you'd think a healthcare facility where you have some residents or something like that that could work for the employee-free clinic, if you will, in addition, to the employee health, which is for mandatory or, maybe emergency type situations. I don't know if they do primary care work, but yeah, that's kind of good. Thank you again, April.
Thank you, Brandon. We have 3 minutes left, so we'll wrap up here. I love this conversation about how might we bring CNAs, PCTs, other frontline staff up to living wage salaries and increase their benefits in creative ways. I'd love to have that conversation with anyone and everyone. As Emily pointed out, this group of researchers is looking for partners in Chicagoland to do similar research that they've done in the Mid-Atlantic region. So if anyone on this call, Rush or Lurie or Ascension, is interested in exploring what that might look like to have this team come in and look at your data and do similar research, let's talk. Feel free to reach out to me and I'll coordinate with their team. It doesn't have to be just one partner. This could be a group effort. So I'd really love to see us do some more research in the Chicagoland region, pilot some interventions, and hopefully tackle this issue that you brought up, Brandon. With that, thank you so much, Emily, Bruce, Preeti, who she's still here on her phone. Got some students waiting to do a tour. Thank you all so much for taking the time to present to us today. I know all of us are eager to hear how the intervention goes and the sort of final data that you collect out of this project. So please keep us apprised and share anything with me that I can pass on to the group. For everyone here, I will include the slides with the recording on our website tomorrow. So you'll be able to, and I'll email everyone who registered for the event with that link once it's ready. And I hope to see you all at our quarterly meeting on next Tuesday, March 4th, 8:30 to 10 a.m. Thank you all so much. Have a good rest of your day.
Thanks.
Thank
Take care. Thank you.
Have a good day.
Thank you, Emily,
you.
Bruce, Preeti, so much.
you so much.
Bye.